Good afternoon. Thank you very much for allowing us the opportunity to present some of these minimally invasive techniques. We're going to take a little different turn, a little different tact, if you will. I'm Eugene, Rhee, and welcome to my hometown of San Diego, California. I hope you all are enjoying it here. Great weather, and I don't think we're going to get any rain this weekend, so enjoy it. How many of you in this room are doing male slings, by the raise of your hand? Okay, and how many of you are actually doing a Transobturator male sling? Okay, so what we're going to do is basically, this is the first introduction into a meeting in regards to the male sling that it was born 3 years ago with an unmet need in regards to a population of men that was growing in incontinence, particularly post-prostatectomy incontinence. So the proposed mechanism, there's been two. One is the elevation and suspension of the pelvic floor muscles, and the second one is a passive compression of the urethra, a simple passive compression of the urethra. Sling tension, the challenges have been, is trying to standardize the sling tension. So in other words, overcorrection simply would mean urinary retention, and undercorrection would simply mean failure or continued incontinence. So there's a balance. The male sling has to address continence, but yet adequate bladder emptying, and certainly patient satisfaction. This is an interesting slide from some marketing data. The slings have caught up with the artificial urinary sphincter. And so you see it in this room that you have people now who are understanding that there is this unmet need with patients who definitively, as evidenced by Victor Nitti at NYU in regards to patients, they simply will choose a sling over an artificial sphincter despite the data in regards to the 30 to 40 year data we have on the sphincter technology. So be that as it may, what we're going to show you is a new way of doing a male sling. What we have currently is an advanced bone anchor sling. This is passive compression. Okay, that's simply all this is. We also have the advanced Transobturator male sling, which is more the elevation of the proximal bulb of the urethra up to the pelvic diaphragm. And now we have a Virtue Quadratic sling. What's the difference? Well, I'll show you what the difference is between this particular sling and what we have today. The advantages here are that, number one, I have a series of approximately 350 to 400 bone-anchored male slings. They simply have too much pain. So we've avoided the bone anchors. We've also gone for broader and better compression, potentially more efficacious for a more severe subset of patients in regards to incontinence. We also wanted to address it and make sure it's simple. And I'll show you how that we're able to accomplish that. And then the other thing finally is we wanted to address ISD with simple compression of the urethra because we feel that this is the main cause of SUI in the men rather than just simply elevating the urethra. What are the potential advantages? Again, what I call this is a hybrid. This is essentially taking the two known theories that we are now addressing and saying, let's use a Transobturator approach for the urethral elevation, and let's do the Pre-Pubic approach, which is basically the urethral compression in a quadratic fixation. I call it a 4-point sling. This is a wider, more elongated compression of the urethral complex. So this is potentially more efficacious for those severely incontinent patients. The other thing you might see is that the J-hook introducer is one introducer. So you can use your dominant hand. We also went with an inside-out maneuver because I felt like in regards to the inside-out maneuver, it was actually a safer operation. And I'll show you some of the surgical pearls in the next following slides. But the bottom line is that we want to make this very simple for the surgeon and simple for the patient, and simple recovery with the efficacy that we can see over the coming several months. So let's, can we go to that animation? So this is a conceptual drawing in regards to this 4-point graft. It's a pre-pubic arms and a Transobturator arms. So what we're trying to do is to rotate this, create an elevation and a compression. And then in terms of fixation, we fixate these in a subcutaneous plane from above and below. So let's go over these steps, and I'll show you it's fairly simple. There's 6 steps. Step 1 is making simply the perineal incision to isolate the bulbar urethra in the pubic rami. You should be able to feel that. Step 2 is to expose the muscle and take it partially off the central tendon. Step 3 is a Transobturator passage. Step 4 is in the pre-pubic passage. And finally, step 5 is the tensioning, and we get to the fixation of these arms. So these are slides of a particular patient I did. This is a patient positioning is simply 90 degrees in terms of dorsal lithotomy. You don't have to put them in a hyperlithotomy. It's easier to pass these needles when they're actually relaxed like this. Unlike Paul, we use Lone Star. I do this alone, and basically the Lone Star is a great assistant for me in terms of exposure. Step 1, obviously, we're all familiar with this, so we are exposing the BC muscle and essentially isolate. You can actually palpate the pubic rami bilaterally at this point. So you expose the muscle and take it partially off the central tendon. All right, so this is about a 2 centimeter distance. There's no science behind this in regards to how exactly deep you need to go with this. I'd say you mobilize it for about 2 centimeters in regards to this displacement. And you see this also with our advanced transobturator technique as well. And here's the difference. So we're talking about a needle introducer that's actually just one needle introducer. It's a J hook, inside out again. And there's 2 slots in it. You'll notice that the distal slot is an L slot, and the proximal slot is a T slot. We found that the L slot is usually used for more obese patients. It's easier to get that suture because you actually have to load the suture on as you pass the needle introducer. So this is a quadratic 4-point sling. The blue is the pre-pubic arms, and the clear plastic is the transobturator arms. This is the J hook. We introduce the suture into the T slot here. Step 3 is just a transobturator passage. Now, one of the things I think is an important surgical pearl is that we've noted, and I stress to you, this is a new approach, a new technique that requires some tweaks over the time, and we're noticing certain things. One of the biggest things we're noticing is that if you pass the J hook way up in the apex, meaning the apex being where the pubic rami meets the pubic symphysis, that's way too high. This design is made for just 2 centimeters below the apex, your entry point, from an inside-out maneuver. So you pass this approximately 2 centimeters below the apex in an inside-out fashion with a J hook, and you basically, it passes very easy as far as this is going through the obturator foramen. So this exits at 10 o'clock and 2 o'clock. So the first slide there shows that the needle has been passed, and then we basically make a nick, and then you isolate the sutures. The blue sleeves you see there, now we're about to undergo the pre-pubic placement. So this pre-pubic passage is 2 small nicks. For a thin guy, another surgical pearl. The pre-pubic arms for a thin gentleman, you actually should go about 2 to 3 finger breadths wider because of the coaptation that occurs. You had a better compression with a wider stance on those pre-pubic exit sites. So if a more heavier set guy, 2 finger breadths is what we typically do. And so then you pass the introducer through the pubic incisions and out through the perineal incision. So this is basically the sling in place and under tensioning. So you tension this. I equivocate this towards like when you're putting on tight pants. You just you're working the TO arms, and then you're working the pre-pubic arms until everything's actually nicely set in place. You'll find this graft to be, it's made out of polypropylene mesh, the inert material that we all use for our pelvic prolapse. So this is basically, again, the transobturator arm elevates the bulbar urethra, and the pre-pubic arm compresses the bulbar urethra. So step 6, finally, is the fixation of these arms. It's just all you simply do is take the tonsil, and you go through the subcutaneous tissue to grab the end of the graft, the ends of the graft, of the arms of the graft, and you bring those through the subcutaneous tissue. So you fixate those within the subcutaneous tissue, and then from a pre-pubic standpoint, we do this as a crisscross maneuver. So in other words, I grab it from one end and bring it to the other site, and then I do it on the contralateral side the other way as well. So again, this graft, in terms of its schematic, you should have achieved this compression as well as this elevation. So in cystoscopic views, this is what you see before, and this is what you see after this placement of this particular graft. So be that as it may, thank you very much, and welcome again to San Diego, and I hope this meeting goes well for all of us. Thank you.